Thank you, Nikki, for the kind introduction. So today, I will not just talk on the antenatal management of congenital adrenal hyperplasia, but also cover some preconception counseling for this topic. So for some introduction, congenital adrenal hyperplasia is a group of autosomal recessive disorder of steroidogenesis of the adrenal cortex, mainly most commonly due to the 21-hydroxylase deficiency caused by mutations in the CYP21A2 gene. Other causes of CAH include deficiency of the 11-beta hydroxylase, 3-beta hydroxylase steroid dehydrogenase, etc. But I will focus my talk on the CAH due to the 21-hydroxylase deficiency. So deficiency of the 21-hydroxylase results in multiple hormonal imbalance, including cortisol and aldosterone deficiency and androgen excess. So based on neonatal screening, the classic forms occurs in around 1 in 10,000 to 1 in 18,000 worldwide. The hormonal production pathway in the fetal adrenal cortex is described here. The CAH affects the MSI21 hydroxylase, leading to decreased production of the aldosterone and cortisol. This negative feedback will increase the production of steroid precursor, which are then diverted into further production of adrenal androgens, resulting in fertilization of female fetuses. So before I talk about the preconceptions or antenatal management for CAH, I would like to ask you, do you think which of the following would be the best choice for CAH for at-risk couple? So keep your answer in your mind and you will find the answer later during the talk. So preconception counseling aims at assessing individuals' patients' pregnancy risk and direct appropriate therapies to reduce those risks. So it should be done at or soon after sexual maturity in patients' teen years. And the counseling should include pregnancy planning. And if there is no conception plan, we should discuss contraception. So for CAH, maternal risk will include infections, including chorioamnionitis, gestational diabetes, and also increased rate of cesarean section. There are potential fetal risks, including miscarriage, fetal growth restriction, and chance of having classical CAH in the fetus. So the partner carrier status is very important because it significantly impacts on the risk of having a child with classical CAH. So comprehensive carrier screening should be considered for those who is having a partner with CAH to assess the couple risk and to optimize the family planning. So before preconception, the maternal status should be optimized and the corticosteroid should be adjusted, and also the dosage should be adjusted. And sometimes if the patient is on other corticosteroid, hydrocortisone may be suggested. So the preferred medications include hydrocortisone and prednisolone because it does not cross the placenta, and dexamethasone should be avoided. And for fertility treatment, glucocorticoid may also reduce the miscarriage rate in some non-classical CAH. For carrier screening, in general population, the carrier frequency rate for classical CAH is around 1 in 60. And if patient's carrier status is unknown, the risk of having a child with classical CAH is around 1 in 120 to 1 in 240. It depends on the ethnicity and also whether there is any factors of consanguinities for the couple. If the couple is a known carrier, the risk will increase to 50%. So from the diagram, when you see that if the partner is a carrier of CAH, when the woman is herself is diagnosed to have CAH, the chance of having the child of 50% of each child would be having a chance of affected by congenital adrenal hyperplasia, and 50% of them would be a carrier of CAH. So it is recommended by the American College of Obstetrics and Gynecology for all pregnant patients or those pending pregnancy to undergo genetic screening for including 21-hydroxylase deficiency. And it is particularly important for infertility couples having workups for IVF because if they are found to be at-risk couple, PGTM may be considered. So for preconception counseling, CAH at-risk couple should be given reproductive options, including natural conceptions, plus or minus prenatal diagnosis, or if there is any ovulatory problems, ovulation induction may be considered. However, if there is fertility problems, IVF plus or minus PGTM may be considered. So if there is no conception plan, contraception should be discussed for women with CAH. Mind you that intrauterine contraceptive device, including copper IUCD or the Mirena, sometimes may be a bit difficult to be inserted because sometimes the vagina may be a bit stenotic for some of the patients affected by classical CAH. And however, because they have usually higher level of progesterone, usually contraceptive implants with use of like progesterone use usually is effective. And however, people may consider use of combined contraceptive hormones in those patients because they not just provide the effects of contraception, it also will improve acne and hirsutism. So these are the flow, and the patient is diagnosed to be having a risk of CAH or there is a fertility problem. So for fertility problem in classical CAH, I will leave this topic to Patricia to talk further. So I will mainly talk about prenatal diagnosis. So the options is including non-invasive testing with cell-free DNA. It usually can determine the fetal sex from as early as 5 weeks, but usually it is for a social use. Usually it is recommended to be tested after 10 weeks of gestation. And invasive testing, including CVS, can be done as early as 11 weeks. Sorry for the typo. So for strategy one, we can use when it is more than 5 weeks, the couple can consider to use the NIPT to determine fetal sex with maternal plasma Y chromosome marker. So if Y is present, there is no need to give the prenatal steroids. However, if Y is absent, assume it is a female fetus, we can consider starting steroid treatment as early as less than 10 weeks. And the dose would be around 20 microgram per kilo per day. And the couple can consider to use CVS as early as 11 weeks for DNA analysis. So if it is an affected female or it is a male fetus, steroid can be stopped. However, if the female fetus is affected, the steroid therapy should be continued till delivery. So for this regime, it can avoid unnecessary steroid in male fetus. However, 3/4 of the unaffected of the female fetus may be given steroid in the early first trimester, which is unnecessary at the end. Can we differentiate the unaffected female earlier so that the steroid can be stopped earlier? So there is a study on the use of parental inheritance by relative haplotype dosage analysis. So it is a study done in Hong Kong. 14 families was recruited with a proband affected by phenotypically classical CAH. So they use cell-free fetal DNA technology and use the Rh2O to have a quicker analysis of the CYP21A2 gene. So these target massive parallel sequencing allow as early diagnosis as 5 weeks, 6 days of gestation. So in 3 of the families, all the cell-free fetal DNA was obtained early enough in gestation to permit starting treatment on only those who would benefit. However, for the Endocrine Society guidelines, prenatal dexamethasone was not recommended for routine use due to the ethical concerns and potential long-term effects on fetal development. So it suggests that it should only be in restricted use and only be used in IRB-approved research studies. The rationale is that it will expose 7 out of the 8 affected fetuses to unnecessary glucocorticoids, which may potentially affect their neurodevelopment and also the brain formation. So then I will talk about the antenatal management. So mind you that the CAH patients, if they are pregnant, it is regarded as a high-risk pregnancy, and it requires coordinated care between obstetricians and endocrinologists. Sorry. Because they are on steroid and they should have enhanced screening for gestational diabetes, and it should be a high index of suspicions for any infections and also preeclampsia. And serial growth in the 3rd trimester should be, growth scans should be provided to monitor fetal growth because there is a risk of fetal growth restriction. And there are a list of increased risks for CAH pregnancy, including not only chorioamnionitis and also increased cesarean section weight and maternal infection. So people have advocated the increased cesarean section weight among those CAH because some of the patients with CAH that they have to undergo prior genital surgery to correct the ambiguous genitalia, and they may have a fear of vaginal birth that it may causing some trauma to the birth canal. And so some of them may opt for elective cesarean section. And however, there is no large-scale studies to find the reason behind why there is a high cesarean section in these kind of patients. And there is also increased miscarriage rate, and also there is chance of adrenal crisis during the pregnancy. So for steroid management during pregnancy, there is dosage adjustment required because for glucocorticoid, usually the dosage will be increased by 20 to 40% from 24 weeks. And the patient should be monitored clinically for regularly during the pregnancy. However, there is no androgen levels that is very reliable for checking the level of the glucocorticoid, because for during the pregnancy, androgen level will also be variable and also increasing trend during the pregnancy. For mineralocorticoid, sometimes there may be increased glucocorticoid lead. However, because of the increased progesterone and also 70-hydroxy progesterone competition for the mineralocorticoid, therefore there is increased use. There is an increased demand for glucocorticoid. However, because usually we will increase the dose of the hydrocortisone, which have a cross effect for the mineralocorticoid effect. Therefore, sometimes the glucocorticoid may not be needed to increase during pregnancy. And for any mineralocorticoid adjustment, sodium, potassium, and also blood pressure should be monitored during the pregnancy to see if there is any need of adjustment. So for adrenal crisis in pregnancy, there are case reports suggesting that it happens during the pregnancy. And it can also be triggered by like hyperemesis, which is quite common during pregnancy because of dehydration. And also, if the patient is having an increased risk of infection, there is also a chance of adrenal crisis during pregnancy. The symptoms of adrenal crisis include severe fatigue and also weakness, confusions and other maternal mental states, and nausea, vomiting, and hypotension. However, you may find that these symptoms is quite common during a pregnancy, and sometimes it may be quite difficult to differentiate it from normal pregnancy symptoms or the adrenal crisis. And therefore, it is important to maintain a high index of suspicions for possible adrenal insufficiency, and patients should be provided an emergency hydrocortisone injection set and receive training for self-injection. So for labor and delivery management, stress dose for hydrocortisone is required because they are on regular steroid, and so usually, bolus injection at labor onset of hydrocortisone is required, and it should be also given every 6 hours in the labor ward. And for infection prevention, prophylactic antibiotic for cesarean section is also very important, and some symptoms for chorioamnitis should be noticed. So for postpartum care for women with CAH, so usually post-delivery, the administered stress dose steroid should be weaned off over several days, and usually it is still at a higher steroid use compared with the pre-delivery corticosteroid dose. And usually early consultation with the endocrinology team is essential during the weaning phase of the steroid. For assessment and monitoring, we should assess the surgical sites for any proper healing, and because there is increased risk of skin and wound infection for cesarean section, and also the perineal wound. And because the patient is on corticosteroid, there will be some healing problem, and so the wound status should be monitored. And newborn screening for congenital adrenal hyperplasia is also essential. And however, routine evaluation of newborn adrenal function is unnecessary. For lactation consideration, and corticosteroids in breast milk, it has very low level of prednisolone, and so usually, even though they are on glucotherapy, and patients are also encouraged to have breastfeeding. So refer back to the question before, when there is a known carrier couples, there is options of antenatal dexamethasone plus early prenatal diagnosis. However, it is not recommended by the Endocrine Society guideline. However, it potentially can prevent sterilization of the affected female fetus, and there is unknown potential long-term side effects from the fetal exposure of dexamethasone. For the options of IVF with pre-implantation diagnosis and selection, there is no need for antenatal steroid. However, IVF and PGT itself have quite high cost, and it also causes stress and risk to the patient. So here are the take-home messages. Thank you.